Ryan Stan here with ASAP Frontline, joined today by Anthony Mazzarelli. One of our interviews here at ASAP 19 in a snowy Denver, Colorado. And a discussion today on something, and that's actually a theme. It's an interesting theme that we found here. We've gotten about 30 recordings here at ASAP 19, and there's been a lot of focus on really not the traditional medications and therapies of healthcare. Looking at the social med, the social determinants of health, and now looking here is compassion.
Yes. And
you've got a book that's out, Compassionomics, the revolutionary scientific evidence that caring makes a difference. Welcome to the ASAP Frontline.
It's great to be here. It's an honor to be here, actually.
Yeah, I really appreciate it, and thanks for making the time. And honestly, thank you for being the person willing to stick around and being the last interview of ASAP 19.
Should I reveal part of the reason why I was really...
You can. I
embarrassingly missed my time. I mixed my days up, so...
But interestingly, this is the first year of recording this podcast that when I've gone to any conference and set up recordings, that in the end we got every single one that we set up.
That's shocking. Who commits to you and then doesn't show up?
Well, because it's busy. You know, there's a lot of things going on. Time slips by. The time changes. You honestly don't know what day it is. I've been here since Wednesday, and I'm here until
I wish
tomorrow.
I could tell you it was something that, cool. I was so lost, and I literally just put on my calendar on the wrong day.
And that's okay, and that's not a big deal. I mean, it's one of those things that it happens. And so, but I'm really excited this year that not only did we fill 28 spots on the list that we had, that we actually got somewhere around 32 to 34 recordings and interviews done.
You could put this in the can and not do another Frontline for a while. You take a
break.
Well,
it's not the middle of 2020.
Right.
And that's what we're going for, is the fact that I want to make sure that we're invested, because I've got here at ASAP, at the Scientific Assembly, the National Conference, I have the highest concentration of some of the greatest minds in emergency medicine and beyond. And so why not take advantage of that to pull them all together, get these interviews done. You know, there's some topical information, things I've got to release first based on time-sensitive nature, but so much of this, especially such as yours, are something that we need to be doing every day, and not for just now, but every day moving forward. And so it's what we would consider in the media side of things, the evergreens.
Yeah,
things
it's an evergreen.
That are always topical, things that are always important. So let's talk about it.
Sure.
Let's talk about compassion. Give me the reason, one, you got behind it and you were interested in it, and then two, kind of the idea behind this is an important thing to
Sure.
consider.
So I'll give you the pathway to writing the book. So my co-author is Steve Tresiak. He is also an emergency medicine physician. He's also internal medicine, and he's also critical care and neurocritical care. But he also has practiced emergency medicine. So what happened is that in around 2014, I was made the chief medical officer where that I work now, which is Cooper University Healthcare in Camden, New Jersey, right outside Philadelphia. And when I got that new role, I was initially charged right away with my boss, the CEO, to improve physician engagement and to improve the patient experience. And I said, okay, sounds great. And they hired a consulting company to help with it. And the consulting company gave me a list of all these things to do, to tell the physicians to do all these different things. I looked at that list and I thought, there is no shot I'm going to get 450 faculty members at the time. Now it's 650. After we just started a brand new medical school, to do all these what seemed like mushy, kind of soft side things. So I immediately turned to our number one NIH researcher, who has more NIH grants, more research, more publications than anyone. Everyone knows who that person was in our institution. And it was Steve Tresiak. And he did research on resuscitation and on sepsis. And I said to him, I want you to be my champion in this endeavor on the patient experience, physician engagement. He said, no way. I'm the science guy. I'm not, this mushy stuff's not for me. So I said, look, I need you to science this up. I need to just find out if there's any data on this. He goes out, comes back, does a lit search, and says, there's some pretty interesting data on this. And then we looked further and gathered more and more data. And what we ultimately did was curate over the course of a couple years over 1,000 abstracts, 280 articles, and literally everything ever written about compassion in healthcare. And then we're able to take that and infuse it with different stories from both of our practices, from our colleagues. And that became the core, and that is the book, Compassionomics. that just came out a few months ago. So he, at the same time, was going through, I won't call it a midlife crisis because he'll get upset with me, but kind of re-examining what he was doing his research on. So he's also turned his research operation to be on this as well. So we do a lot of original research at Cooper on compassion. The reason why it's called compassionomics, if you think economics is the study of the economy, genomics is the study of genes, this is what we call compassion science. And it's looking at the impact of compassionate care on patients, meaning outcomes, patient care, meaning costs, and then burnout, which is the impact on providers themselves.
I think this is something, because it's always a discussion in emergency medicine. And what happens with burnout? We get jaded. And I think one of the first things to go is the compassion. And a lot of times we feel like we're putting up walls to protect ourselves, and just with everything we've seen we see terrible things, horrible things, sick, dying, suffering. And so I think, in that effort to protect ourselves, a lot of times we forget, what we're there for. One, that we're human. Two, that they're human. And that wall goes up. That I think one thing that is lost is compassion. With all the research and everything that you've done, what is the physical, not just warm and fuzzies, the physical impact of compassion?
So I want to address everything you just said, because it's fascinating, right?
Because now I can order your book while you're doing it.
Please do. So
I'm doing it right now.
So let's talk about the first thing you said, right? Which is the concept of burnout is exactly what you said. It's depersonalization, it's emotional exhaustion, okay? And not seeing reward in what you do. And so I was always taught in medical school, and it sounds like you were too, hey, don't get too close.
Yeah,
if you get too close, you're gonna get burned out, right? If that were the case, then in the literature you would find where there was more compassion, there'd be more burnout, right? Turns out it's actually the inverse is true. It turns out that compassion and connecting more with patients is actually one of the antidotes to burnout. When you connect with patients, and now we're not about empathy. Empathy is where you can sense someone else's emotions, right? Their negative emotions, you can feel it. Compassion is empathy plus action. It's where you actually do something about it. It turns out that when you do that, you actually light up the reward pathways in the brain. So there's tons of neuroscience data about this, where you can actually forget your own problems by diving into patients and providing, not just anybody, when you provide compassion. So empathy hurts, but compassion heals. Not only the patients, but yourself. But let's talk about your other question about the physical effects, right? So there are 22 different mechanisms through which how compassion can actually help patients. So physiologic, psychologic, all these different ways. I'll give you a couple pieces of data. So if you say, okay, well, how does it help? One way, they did a study where there was high compassion physicians, and these are all standard tools. Primary care physicians who had high compassion, their patients had an 80% higher fold of having normal glucose levels if they're diabetics. If they're diabetics, 80% higher fold of having a normal cholesterol, and 40 times higher odds of not having any acute diabetic complications. If you take the common cold, people have a interaction with a physician that is of high compassion, actually have their common cold for a less severe and less number of days. This is all documented in all different studies that we went through. For surgeons, if there is a surgical, if the anesthesiologist can go and connect with the patient in a compassionate interaction before surgery, or a nurse, it's been shown that they need less anxiolytics, and then they end up getting discharged sooner, so length of stay goes down, and less use of opioids. And lots of studies about how it can actually alter the way you sense pain if you increase that compassion that you have and that connection between any provider and any patient.
What's amazing, though, I mean, and we've seen that, and I think it's something that we don't consider enough, is how much the brain and the reward pathways and emotion honestly drives the condition, the pain. I always remember, at a point in life where I was super stressed about performance and everything else. I mean, it's not that I'm not now, but at that point I was super stressed about it, and I was getting to the point that I was getting honestly sick with it, like physically sick, like recurrent colds and illnesses every single year, almost at the same times every single year, a lot of times around really high stress times. It's amazing what the body drives in terms of physical, not only illness, but also the potential for recovery and wellness, just by that emotions and interactions. We know that the interactions that we have drives so much in our lives, whether it's professionally, whether it's in our case, with our patients, no matter what it is. I mean, we did a podcast earlier, and just having close friends, close family, support network makes a huge difference in suicidality, makes a huge difference in depression and self-harm and self-worth. So it's incredibly...
Yeah.
So these interactions in our emergency department are key because they're turning to us because we are, to them, the expert in this arena. And so they're turning to us, and we can make all the difference in the world in how we engage them and at least having that compassion. And I find, though, that especially after a long run of shifts, you get to the point that you're just... You get frustrated, tired, and really it's not even tired of the patients. It's really tired at the inefficiencies, at the metrics, and everything else that we're dealing with. And that's why I think a lot of these things are so important that are outside emergency medicine, because honestly, if you gave me that interaction to the patient, and that was all it was, I could die an incredibly happy man.
Listen, physicians see patients for free. We get paid to do paperwork, right? I mean, that's
that's true. Yeah.
But, it's interesting that you talk about that because a couple things that you hit. I mean, you're hitting on all those points, right? Mm-hmm. I do not mean to belittle anybody who comes on and talks about wellness and focuses on escapism. So escapism is what we call when you say, "Oh, listen, here's how you get wellness in your job. Hot yoga, long walks in the park, like all that stuff's great." But we refuse to believe that the best way for you to engage and enjoy your job is to get as far away from your job as possible. Mm-hmm. We have to actually make it, there has to be something at the point of care that makes it better for us in our jobs. And that's what they have found in data is actually diving into the patient care and actually having that connection with patients, which I think is something that we don't think about that enough. We invest money in wellness programs that are things, not that they're not important, but let's try to improve things at the point of care where, like you say, you're not thinking of it. It's all the stuff that you don't like.
Yeah, it's the surrounding. It's all the little satellite things that are flying around our little planet and interactions with each other. And it's not because so boil it down. If you're sitting out there right now, you're frustrated at work, you're burned out, not great with patients. I mean, you're going in there, you're kind of feeling kind of snarky. Is that because of the patient or because of everything around it? Because honestly, one of my favorite things that I deal with, I love talking to little old ladies. Remind me of my grandmother, sitting there with them. They're super sweet little 95-year-old ladies who, they're, they can't hear worth a dang. They're not going to win a weightlifting competition, but just being there and with them, it almost always makes me, smile and feel better about things. And so we got to prioritize the fact that what we're talking about with the compassion, and of course, I'm kind of getting off the rails here.
Yeah, it's your podcast.
I took an exit rant here, and but to build that compassion, to build that connection with our patients, to understand really what we got into this for, is what gives us value, and then what is stressing and burning us out is all that surrounding stuff, and that's what we have to address. And so when I think about wellness, I'm thinking about the fact that we got to deal with the fact that there's, these mandates of things that don't have strong
Correct.
Evidence. The inefficiencies that could have been fixed but aren't there. Whatever it may be, or the EMR that's inefficient or keeps warning you 87 times a day. Right. But it's important, though, because as you state in the book, 40 seconds of compassion can save a life.
Yeah.
And so we have to reinvest because our primary goal is to accurately evaluate, diagnose, and treat a patient to get them the best outcomes that we can possibly get. And we may be ignoring the one that actually has one of the greatest impacts on outcome.
Absolutely. And not only on outcomes, on costs and on us as providers, right? Mm-hmm. It's a total win-win. And, we talk about 40 seconds because in 5 different studies that measured this, there were meaningful compassion interventions, all took less than a minute and didn't extend the visit. And so that's why we talk about it takes less. It doesn't take, because people think, I don't have time to be compassionate. Mm-hmm. They tend to think of it like dessert. Like, well, I'll do the medicine. Like, I'll eat my entree. If my belly's, not too full, I'll sprinkle in, I'll have dessert, or I'll add on the compassion. Mm-hmm. We need to move it into the evidence-based column, and it needs to be part of the actual care that we give. And it's actually the only type of medicine we can give where we actually benefit from it, when you think about that burnout aspect of it. Mm-hmm. And, to bring you some data from the emergency department, we did, it's not in the book because it's just original research we just published recently at our institution. And I never knew this, that 25 to 30% of patients who actually have a life-threatening condition in the emergency department within 30 days develop the criteria for PTSD. I did not know that until we embarked on the study, but that's a baseline in the literature. We did a compassion intervention where we put a medical student who were trained at the head of the bed, speaking into the patient's ear, touching their shoulder, whether it was pre-intubation or whatever the resuscitation was, and we saw a significant decrease in those that had PTSD criteria at the end of 30 days. It's amazing, right there in the ED.
It's pretty impressive. And so that rolls me into, you got your, where you're training your medical students there. What are some of the simple steps things can do? Because, some people, one, they may feel like they're compassionate. Two, they may say, how can I do it more? Or how can I even invest in it? They're looking at themselves in the mirror right now and saying, yeah, I've been kind of disconnected from this thing for a while. What are some of the steps and things that the physicians, PAs, NPs, other health professionals that we're talking with now on the podcast, that they can do to kind of refine this?
Sure. So a couple things. One is eye contact, right? You want to connect with the patient. Sitting down can help while you're talking to a patient, because there's for a number of reasons, but one of them is they've done studies where the patients actually believe you were talking to them longer than you actually were when you sit down. So sit down, you make eye contact, and you just make that connection. And you have to just be purposeful. Anything we do really well in emergency medicine, it's because we practice and we're purposeful about it. So compassion needs to be the same way, in which you're not interrupting, you're really looking someone in the eye, and you're not. And then if you lean into patients, it doesn't have to be that much time. That's when you will see the benefit as well as the patients. So that's really the first step. The first step is, like you said, you sometimes get lost in that conversation because you think about the little old lady, you think of your grandmother. It's to actually give that 40 seconds or so of compassion to a patient. Sometimes it's even doing it with the staff. You get the same benefits if you do it with the staff. And that's where you can start to reconnect and light up those pathways in the brain and decrease negative emotions, and we get the benefit, but the patients get the benefit too. $100 to $329 billion every year is wasted on health conditions because people don't adhere to medications. And there's tons of studies that if there's a compassionate connection between the doctor or the nurse or the APP or anybody and the patient, they're more likely to be adherent to their medications. It's amazing.
That's fantastic. I think it's impressive, and I'm glad that we were able to find this one time since you decided to ditch me yesterday.
Fair, all fair.
Because I think it's great information. And when we're looking at wellness, I completely agree with you that I think there's important things we can do to kind of take care of ourselves some. Because as physicians, I think there's so much where we ignore ourselves, our health, our fitness, our diet, all those types of things. But how can we advance that wellness in our departments? I mean, why not, if you've got an enemy, and if we're at war with an enemy, why not go to war with that enemy where they are, as opposed to finding another battle somewhere and thinking that one's going to go away? And if we're saying we have burnout in our emergency departments, we need to address the emergency department. I love everything else we're doing. And a lot of that is stuff because we've spent so much time just focusing on medicine that we've ignored ourselves, our health, and everything else. But in our departments, how can we make them better? And this is great because it doesn't require administration to get involved.
It doesn't, although I would say there's a list of things we can do as providers, but then there is still a list of things that leaders can do for physicians in the emergency department, no matter where they are. But there's some things in your sphere of control when it comes to compassion, and there's some things that leaders, and there's plenty of leaders that listen to this podcast as well, that they can do. So I think there's a lot that can be done, but this is the wonder drug of the 21st century.
Just having a little bit of compassion.
Yeah.
And actually, you can have a little extra order of sweet potato fries tonight or whatever you like, because I've got your book heading to my house right now.
Well, all of the proceeds from the book go to our foundation at Cooper, and half to the foundation and our philanthropic efforts, and the other half is into furthering research on compassion.
All right. Well, then they can have some sweet potato fries. Some of my favorites. How can folks get more information? The book is available everywhere. Of course, Amazon, usual places. I was able to order it during one of your answers, so it wasn't very difficult. And I did it here after the last podcast had some Canadian whiskey and bourbon involved.
By the way, I feel terrible. You're buying my book, and the last person literally brought you
Well, that's Ken
Canadian
Milne.
maple whiskey. Like
He's
that's
Ken Milne. He's one of the biggest podcasters, foamed people in North America.
yeah.
I wouldn't say in the United States because he's Canadian, but in the entire in North America. And yes, we decided to do that earlier this week because I'm from Kentucky and I wanted to reach out an olive branch to him.
So did you bring bourbon? And
That's the
This is the
Calumet,
bourbon?
the 12-year Calumet. Right
Oh,
there.
well, there you
So that's
go.
one of the products that's within. Actually, that farm is about 10 miles from my house. And he brought that, and we thought that we would do our part for international relations between Canada and the United States to make sure that we have strong and long-lasting relationships to advance the health care of North America.
So did you drink this during the podcast?
For his, yes.
Yeah. So I will point out, I know you shouldn't do visuals on radio, but his is almost empty and yours is almost full. So what does that say about what happened during the podcast?
Well,
Did he drink that much more than you?
No. And that actually says that that one actually came already used, where he's as Canadian as he can be, has been incredibly generous and has been giving out samples probably for the last 5 to 6 days. And so his olive branch has been more
Picked?
Yes, exactly. Thank you. And mine I saved for this because I was afraid that if we got too many people knowing that there was a 12-year Calumet, that it would be taken care of too quickly. And I wouldn't have any to share. And then we have an international incident with our friend.
Yeah,
Kim Milne.
we can't have that at
No,
ASAP.
absolutely. How can folks get in touch with you if they have any more questions?
So they can go to compassionomics.com. So that gives them information about the book. It also, they can not only contact Steve Trzeciak and I, but they can give us their own stories of compassion. And then we'll collect those and maybe use them in a future book. Because we do a lot of stories that are in the book. So compassionomics.com is where they can find out about the book and also get in touch with us.
And this is a wrap for ASEP 19. About 32 to 33, 34, I don't know how many recordings involved. Snowy days here in Denver. Hopefully we will be able to successfully get out back to our homes here tomorrow. But as for me, you can contact me, youreverydaymedicine@gmail.com, youreverydaymedicine@gmail.com, or @everydaymed on Twitter. And until next time, I'm Dr. Ryan Stanton, and this has been some ASEP Frontline.